Zoom, so
yep.
It's not my bread and butter like Teams is. Can people see that? Yeah. So I thought I'd just give you a quick 5-minute rundown and an honest account of carrying out GPPS in Uganda, which is where we carried it out. So we went to 2 hospitals in northern Uganda that were in the same city. One was a kind of semi-private hospital and one was a regional referral hospital, so not private. And we had various experiences with GPPS. So initially we did a pilot phase of GPPS in our scoping visit, which was April 2019. And that really gave us all a practical insight into GPPS. So all partners, so our Ugandan partners and also the UK kind of leads. And it meant that we were able to identify training issues with our Ugandan partners, which we could rectify. So I think we hadn't anticipated the level of experience, clinical experience, some of the pharmacists didn't have in Uganda. You know, they were very dispensary based and weren't familiar with looking at drug charts and looking at notes. So it meant that we were able to actually, you know, do a bit of training on the wards, identify what sort of training issues and really sort of tailor training towards the data collectors. We then went and did a full GPPS in October 2019. So this was 2 sites across 2 days, and it was our Ugandan and UK team. And it was great because actually since we'd gone in April and come back, our Ugandan pharmacists had gone on the wards more. They, you know, really developed an enthusiasm for questioning antibiotic prescribing. And actually it meant that our Ugandan partners were able to lead the GPPS in certain areas. So I didn't have to sort of oversee all of the data collection. Our Ugandan pharmacists were able to actually oversee some of our UK team who hadn't been to Uganda before. So it was great in that aspect that, you know, although initially GPPS seemed quite daunting for us all, it was quite quickly rectified with just doing a pilot phase together. And these are just, so Stephen at the bottom is a pharmacist from Manchester who also works at Health Education England, and he is sort of working through the GPPS on the pilot with Sister Josephine, who was one of the lead pharmacists. And it also gave us the opportunity, while we did the pilot, for our health psychologist, Eleanor, who's at the top, to get out and talk to some of the nurses and the other staff about barriers to antibiotic prescribing. So I just thought it was useful to show you a couple of examples of the types of prescribing that we saw. And again, part of it was really getting our heads around what were we seeing and what does this mean. Not all people use drug charts, and actually the doctors didn't prescribe on drug charts. It was the nurses who transcribed. So these were administration charts. So you can see from the top, we've got an antimicrobial prescribed. And you can see the sort of, did this patient have all of the doses on the days they were prescribed? And actually, did they have 1 or 2 doses a day? Again, in the middle, we've got pen. And has the patient had any of that at all? And on the next one, you can see on the top, which is Ampiclox, the OS is out of stock. So we have an out of stock there. And then we don't have any other antibiotics to replace the Ampiclox. We've got a bit of metronidazole at the bottom, again, Metro, and we've got an out of stock. So it was really trying to figure out what was prescribed on the drug chart, you know, what these abbreviations meant, and actually what had the patient had, and trying to marry these up with the notes as well. So it wasn't all as big a challenge as this, but these were some of the prescribing challenges that we faced. So our pilot was really useful because actually our pilot really meant that we could tailor the prescribing training and the AMS training that we came back in October to do. So our pilot was around about, it was just over 70 patients. And actually we were able to focus on some of the positives. So we saw a really good rate of documentation of indication, and we saw a good rate of documentation of stop and review date. And we were able to reflect on this with our partners and say, actually, you're doing this better than we are. So, you know, it was good to be able to have some positives to give back and some good reflections for actually, could we use this practice back in Manchester? So we can see, we really thought out of stocks would impact on our data, but actually, if you can see the top pie chart, yes, out of stocks did impact on some of it, but it wasn't as big a problem as we thought. We were also able to sort of show the rate of non-compliance with guidance and also the reasons for non-compliance. And we did highlight quite a lot of indications that weren't included in the Ugandan guidance. So actually, how can we assess whether this meets the guidance if there isn't any guidance for this? And again, we really split it into why doesn't this fit the guidance? What is it that we need to focus on? So problems encountered, well, it wasn't a problem, but I did meet a mouse, which I was quite surprised to meet on my first visit to the ward. It looked a very clean mouse, but I was slightly shocked to see a mouse. But one of the main problems that we encountered initially, and that's why it was good we had done a pilot, was that familiarity with the notes and the drug charts for our data collectors. And also the lack of drug charts in some areas. Sometimes they didn't have paper to print drug charts on. So it was just really thinking outside the box. Where can we get this information on the prescribing? We often saw that actually drugs were prescribed in the clerking section of the notes. So the patient would come in, be clerked, and in the middle of the clerking notes, the doctor would prescribe a drug, but actually not communicate that with the nurse as well, that was what was prescribed. Out of stocks obviously were an issue, and indications, as I said, being treated that weren't included in national guidance. And again, that Wi-Fi for GPPS data inputting was an issue, but we overcame it with the fact that I had Wi-Fi at the accommodation, so we were able to do more that way. But overall, GPPS was a really good, useful tool for our project. That initial phase, when I saw the GPPS, I thought this is going to be a nightmare, but actually it provided such good insight to what the problems going on in the local problems were, that actually were different to what we anticipated they would be. So it gave us that excellent insight into what we needed to include in our training and how we tailored the training towards it. And it got us all talking openly and honestly. Sometimes when we're having meetings with our partners, we can miss the point, and also sometimes it's quite difficult to have those open conversations and really get down to what the problem is, especially if our partners don't necessarily know what the problem is. So it enabled us together to talk openly and honestly about what was going on, and also identified those barriers to using the guidelines, which some of us hadn't even considered or expected were barriers. And it was a great opportunity to do some on-the-spot AMS training with our partners. And actually, Zainab, who was one of the lead pharmacists, after discussion with me on the ward, she went and challenged somebody on the prescribing, and I was like, wow, just, I don't see our junior pharmacists do that, but she was straight in there. And, it was great to sort of sit back and watch the interaction. It also gave us some realistic ideas about what we could do. So after the big GPPS, we identified some local audits that we'd like to tackle. So cellulitis and pneumonia guidelines and the sort of practice in those areas seem to be problematic. So really, can we focus on those going forward? And our Gulu partnership doesn't exist anymore because of different political issues in between healthcare organisations. Our Manchester link doesn't exist anymore. But actually, I've kept a link with the pharmacists, and also there's another fellowship, there's the IGH fellowship program going on. And so I'm actually sort of giving some consultation advice in that, because they're trying to do some more PPS back in Gulu as well. And they participated in the WHO PPS last year too. So it's great to see actually this experience didn't put our partners off. They enjoyed it and they thought it was useful. So although to us initially it seemed like quite a big barrier to overcome, actually our partners really saw the value in it. So that's the end of my presentation. I hope you found it a little bit useful. And we'll try and...
Fran, can you just have the first slide back up for a minute, please?
First one?
Yeah, the very first one.
That one?
Yeah, it's a slideshow. Okay. So one thing I forgot to, thank you, Fran. One thing I forgot to ask earlier was what people wanted to get out of today. I know you've sent us some information on the on WhatsApp, and apologies. Thank you, Fran. And apologies that we can stop the recording. Actually, I'll stop the recording.